Respected chairpersons, my dear teachers here, good morning, dear delegates. At the outset, I would like to thank the Trichu Cardiology Club for this opportunity. And I'll start with this disclaimer. Absence of ECG changes does not exclude ACS, even though we are going to discuss regarding the ECG changes. So, when acute coronary syndrome is suspected, we have to do an ECG within 10 minutes of the first medical contact. That 10 minutes is important. Just like the guidelines the committee has put me, you have to finish your talk in 10 minutes. You have to take the ECG in 10 minutes. So, based on the ECG, we can classify into NSTEMI as well as STEMI. STEMI means there is ST segment elevation in more than 2 contiguous leads of more than 1 millimeter, except in V2 and V3. And NSTEMI means there is no ST segment elevation. It can be ST segment depression or T inversion. Generally, NSTEMI is considered as a non-occlusive myocardial infarction and STEMI as an occlusive myocardial infarction. We will discuss that later. But in STEMI, all STEMIs are not equal. What are the important points? So you look here, this is an inferior myocardial infarction, and here this is an anterior myocardial infarction with ST segment elevation in anterior leads. Here, obviously, the anterior myocardial infarction has got ST segment elevation in more leads. So, if you take the number of ST segment elevation leads and total ST deviation, if the deviation is more than 15 millimeters, it has got higher risk. If you see the left hand side, it is a low risk situation. Anterior MI generally has got large area of myocardial infarction. About 50% of the myocardium is supplied by the LAD. Here it is a proximal LAD occlusion. Whereas inferior MI, probably the myocardial involvement is less. And if you look at this ECG in the right side, it has got tachycardia. Generally, anterior MI has got tachycardia. Tachycardia, heart rate of more than 100 per minute has got worse prognosis. If you look at the ECG pattern, this pattern on the right side is called grade 3 pattern and the left side is called grade 2 pattern. In grade 3 pattern, there is a distortion of the terminal part of the QRS with ST segment elevation. So, this grade 3 pattern is also a high risk pattern. So, there are certain features like area of myocardial involvement, the extent of ST shift, grade, the rate, and also the width of the QRS is also important. But all inferior myocardial infarction does not have that low risk. Sometimes it may be associated with a RVMI where there will be ST elevation V3R and V4R, and posterior MI where there is ST elevation in V7, V8, V9. So, always we may look at the special leads. Widening of the QRS, whatever be the pattern, whether it is LBBB, RBBB or non-specific, always has got a worse prognosis. If you look at this pattern ECG, this ECG has got a left bundle branch block pattern with V1 is negative wide. And there is ST segment elevation in lead 2, which is a concordant ST elevation. That is, the ST elevation is in the same direction of the QRS. And there is ST segment depression in V2, that is concordant ST depression. So, this satisfies the modified Smith-Scarbosa criteria for acute myocardial infarction left bundle branch block, and this is considered a STEMI equivalent. Here, there is ST segment elevation in V1 in the circle. V2, the ST segment elevation associated with the QR pattern. This is right bundle branch block, QRBB pattern with ST elevation myocardial infarction. This suggests a proximal LAD occlusion. So, in anterior myocardial infarction, whenever there is a right bundle branch block, it has got high risk. And when there is associated a left anterior fascicular block or posterior fascicular block, the risk increases. And this one pattern you have all seen, there is ST segment elevation is so huge and it looks like a tombstone. So, such a significant ST segment elevation is associated with high risk. So, these are certain features which suggest high risk. But then, let us go into another term called occlusive myocardial infarction. 25% of NSTEMIs. So, classically NSTEMI is said as a non-occlusive MI and STEMI is an occlusive MI. But 25% of NSTEMI actually has got occlusive MI. Coronary arteries occluded, and 50% of the patients with occlusion does not have STEMI. So, actually occlusive MI and STEMI are not equivalent. So, probably there are other ECG features which may suggest an occlusive MI where you may aggressively treat. So, you look at this ECG. By the definition, there is no ST segment elevation and you cannot diagnose STEMI. But if you look carefully, there is ST segment depression V1, V2, V3, ST segment depression V1, V2, V3, which terminates in an upright T wave, and there is a prominent R especially in V2 and prominent R in V1. This is posterior wall MI. This is isolated posterior wall occlusive myocardial infarction where 12-lead ECG can fool you, and this is a STEMI equivalent. You may take a posterior lead V7, V8, V9 to diagnose this properly. Another patient, a 45-year-old person, presented very early, 1 hour after cardiac pain. And if you look at this ECG, there is no ST segment elevation anywhere. Should you go aggressively with treatment? But if you look carefully, there is a tall T wave, and this tall T wave is a hyperacute phase. And this hyperacute T wave may be the early phase of myocardial infarction evolving pattern. It may go into ST segment elevation. So this is again a STEMI equivalent as per the ACC definition. And don't miss an inferior myocardial infarction just because the ST segment is very subtle. Subtle ST segment elevation in 2-3 AVF can occur. And the clue is that the reciprocal change in the AVL. And there is a tall T wave here also. There is a slightly hyperacute tall T wave. So this is an inferior myocardial infarction with subtle ST elevation and reciprocal changes in AVL. What is this ECG? This is a patient with a classical cardiac pain. If you look at this ECG, there is no significant ST segment elevation anywhere. Should you diagnose STEMI or should you diagnose occlusive myocardial infarction? Just like the previous ECG, you can see that there is a very prominent tall T waves in the chest leads. And not only that, there is some ST segment depression in V2, V3, V4, V5 also. So there is, this arrow shows ST segment depression which culminates in upright tall T waves. This is known as the D Winter pattern, an ST segment depression in the chest leads, 1 to 2 millimeter, which culminates in an upright T wave. It's a D Winter pattern. It is suggestive of a proximal LAD occlusion, and approximately 2% of the anterior myocardial infarction present like this. And it is again can be considered as a STEMI equivalent, even though it is not mentioned in the ACC guidelines. So we can look at another pattern. Look at this ECG. So by definition, STEMI means contiguous leads. More than 2 contiguous leads should have ST segment elevation. This patient has a classical cardiac pain. If you look here, the ST segment elevation is in AVL and V2. It is not contiguous leads. But there is some ST depression lead 3 and minimal ST elevation may be there or may not be there in lead 1. So the ST change is in AVL and V2. And this is a specific pattern called South African flag sign, where AVL and V2, this shows ST segment elevation. As you go down here, there is ST segment depression in lead 3, and there may be ST segment elevation in lead 1. This resembles a South African flag, and this is classical of a D2 occlusion. D2 is the major or D1 occlusion, major diagonal arising from the LAD may be occluded, and this may extend to the LAD also, and this patient may have a worse prognosis unless you recognize this and manage this as STEMI. Okay, another patient who has presented with chest pain, and this patient does not have ST segment elevation. If you look at this ECG, it's a 50-year-old male patient with classical cardiac pain, and if you look at here, there is some ST segment elevation, minimal, but this ECG is classically a biphasic T wave. So this is known as Wellens pattern, a patient presenting with chest pain having a biphasic T wave, and this is Wellens pattern type A. And there can be Wellens pattern type B, where there is a deep T inversion in the anterior chest leads. So there are 2 patterns of Wellens, and both represent a possibility of a proximal LAD occlusion in about more than 90% of the cases. Wellens B is more common, and the important thing is that this pattern is seen when the patient is pain-free. At the time of pain, this pattern may not be seen and the ECG may be normal. And when the patient is pain-free, this pattern may be seen. And if you don't suspect a proximal LAD occlusion, you may manage less aggressively because you think that it is a non-ST elevation MI. Probably this patient will need aggressive management. Another ECG. This patient has got a classical cardiac pain. You are diagnosing myocardial infarction. Look at the ECG, not much ST segment elevation. There is an ST segment elevation lead 3, some ST elevation AVR. But if you look carefully, there is ST segment depression V4, V5, V6. And there is ST segment elevation on lead 3 only. This is known as an Aslanger pattern. This Aslanger pattern is associated with a circumflex occlusion or RC occlusion and also associated with multivessel disease. This is something known as shark fin sign, where a patient with ST elevation has got a particular pattern, and this is associated with LMC occlusion and may be associated with significant coronary artery disease and high mortality. Some patients can have left main coronary artery occlusion, which may be associated with ST elevation in AVR and V1 only, but gross ST segment depression in multiple leads. So this is not a STEMI equivalent, not an indication to thrombolyze, but this has got high risk. So this is again a STEMI equivalent. LMC occlusion where there is AVR and V1 ST elevation and ST depression in multiple leads. So there are STEMI equivalents which may be a posterior MI, left bundle branch block pattern, D-Winter pattern, or hyperacute change, or there may be a AVR ST segment elevation which may suggest a LMC occlusion, or Wellen syndrome which may suggest a proximal LAD occlusion. One more sign, last sign, is a NSTEMI presenting with a N sign, that is a terminal part of this ECG looks apparently normal, this is NSTEMI, but terminal part of lead 2 shows a notch, and this notch is known as the N notch, which may be seen in 10% of NSTEMI and may suggest a LCS occlusion. So I have discussed certain signs and certain patterns which may suggest a clue for a high risk situation in acute coronary syndrome. Thank you so much.